In this video, I'll be arguing for the use of multiparametric MRI instead of biparametric MRI for prostate cancer diagnosis. Here are my disclosures. Many people will point to these advantages of using biparametric MRI for prostate cancer diagnosis, chiefly faster examination times, reduced costs, minimizing contrast medium related adverse events, particularly intracranial gadolinium deposition. And almost all people will point to the fact that biparametric MRI can define negative cases and so can reduce the number of men undergoing biopsies and help reduce indolent cancer detection rates, which are the main advantages of prostate MRI. Meta-analyses such as these can be found in the literature. And if you look at point estimates, you can see that the sensitivity and the specificity of biparametric MRI on the left and multiparametric MRI on the right are similar. But the most important thing to note is the spread of the data. If you look at the spread of the sensitivities of biparametric versus multiparametric, you can see that there is a greater spread of sensitivities for biparametric compared to multiparametric MRI. Here is the Cochrane review that evaluated the factors that affected the ability of MRI to detect clinically significant cancers. What they noticed was that contrast medium use did not affect the ability of MRI to detect clinically significant cancers. But if you look at the detection ratio, the ability of MRI to improve upon the detection of clinically significant cancers compared to trust biopsies, you can see that the detection ratio for multiparametric MRI was larger but not clinically significant. The Cochrane review advises on the use of linked ROC plots to get a sense of how much of a change in accuracy occurs within a study by noting the consistency of the change with and without an intervention such as contrast medium enhancement. So if you look at this paper and look at the paired studies where biparametric MRI was compared to multiparametric MRI in the same patients, what you notice is that the arrows either move to the right or upwards in 7 out of 11 cases. So what we can see from this is that in the paired studies there is an increase in sensitivity for multiparametric MRI. Now clearly this is a small effect, but it does occur and it is detectable. This is one of the studies that evaluated this. In this study they showed that dynamic contrast enhancement was an independent predictor for cancer detection of all cancers and of clinically significant cancers in the peripheral zone, and noted that DCE positivity increases the detection rates in PIRADS categories 2, 3, and 4 by 16, 16, and 9% respectively. Again showing in this particular study that there was a small incremental benefit in the use of contrast enhancement when looking for prostate cancer. And here's a prime example of a patient who seems to have a PIRADS 3 abnormality in the peripheral zone, asymmetric, low density change, mostly linear. But you can see here on the B2000 that there is a focal area of hyperintensity corresponding to a low area of ADC. Now, many people would not call this a PIRADS 4, but on the contrast enhancement, it's quite clear to see that this is a PIRADS 4 lesion 3+1 because of that focal area of abnormal enhancement. And indeed, this turned out to be a 4+3 cancer on a targeted biopsy. But we're not really here to discuss sensitivity and specificity. More importantly, it's important to know what the patient impacts are. Now we know from level 1 evidence that the MRI pathway reduces the number of men undergoing biopsy after a negative MRI. And we know that it reduces the diagnosis of insignificant cancers because fewer biopsies are done overall. This is level 1 evidence. We also have a hint that there is some improvement in the detection of clinically significant cancers, particularly for men who've had a previous negative biopsy, but the effect is rather marginal. What does the biparametric MRI show? If we look at this theoretically, we can see that we can diagnose negative cases by the use of T2 and diffusion imaging alone, so the major benefits of MRI should be realizable without the use of gadolinium. That is to say, reducing the number of biopsies and reducing the number of patients with insignificant cancers. And in fact, this turns out to be true. So here's a very large study called the BIDOC study, which was published in 2018, looking at over 1,000 men. And in this study, you can see that about 30% of men avoided a biopsy after a negative MRI, and there were 8% fewer cancers. And like many other studies, showed that there was no improvement in the detection of clinically significant cancers. So the BIDOC study in a single center certainly seems to indicate that biparametric MRI in an expert center would be able to deliver the major benefits of MRI. Now I've put the BIDOC study together with the Gothenburg study, which are again both prospective studies but looking at biparametric MRI. And you can see the detection ratio, the ratio of comparing the detection of clinically significant cancers compared to trust biopsies is under 1 for both studies. However, if you look at the MRI first study and the 4M study, you can see that the detection ratio is above 1, more or less 1.1, again indicating that there is a slight improvement in the detection of clinically significant disease compared to trust biopsies using the multiparametric MRI approach. So what we can say is that biparametric MRI can reduce the number of men undergoing a biopsy after a negative MRI, which we expect. It does reduce the diagnosis of insignificant cancers, but less than in multiparametric MRI. And there does not seem to be a benefit in terms of improvement of clinically significant cancers, but we didn't see that with multiparametric MRI anyway. The real question is, does it reduce the number of cores per patient in positive cases? Well, if we look very carefully at the comparative performance of multiparametric MRI and biparametric MRI in this reanalysis of the 4M study, what is quite clear to see from the plots is that there is an increase in the number of PIRADS 3 cases when you went from a multiparametric to a biparametric technique, and when you went to a really fast biparametric technique, then that could increase up to 75%. So the real question you have to ask is, how much would PIRADS 3 proportions increase in the real world? Well, we now know that PIRADS 3 cases occur in approximately 20% of men in the first biopsy situation and in about 33% in men who have had prior negative biopsies. If this value increases by anywhere from 20-25%, which is the biparametric approach, to 75%, which would be the fast MRI approach, then would that be acceptable? Because of these concerns, the PIRADS Steering Committee does not make any specific recommendations on the preferred use of biparametric MRI. And that's because they are concerned about the technical factors leading to suboptimal image quality for diffusion weighted imaging. So what they say is that there is a preference for multiparametric MRI use when clinical factors indicate the likely presence of clinically significant disease that should not be missed. So for example, if you are at high risk because of family history or a prior negative biopsy, or the risk calculator said that you were at high risk, then you really should have multi-parametric MRI. My own view is that if you have an extremely low prevalence of clinically significant cancer, such as in the screening setting, then biparametric MRI may be adequate. Similarly, if you are at very high risk, so your PSA is very high and you are DRE positive, then you are unlikely to benefit from the use of contrast medium. So if you had a tumor like this, at 98 PSA, abnormal DRE, then clearly there is no role for giving dynamic contrast enhancement because all the findings, including the bone metastases, are visible using the T2 and diffusion sequences alone. However, we have to assure the quality of the scan and the reporter. So the recommendation is only do biparametric MRI at high volume centers. Here's some data that was recently published showing how much expertise you needed for a biparametric MRI compared to a multiparametric MRI. So for example, if you wanted to pick up all the true positives that were there, in a biparametric MRI, you would have to perform 1,000 cases. With a multiparametric MRI, you would need an experience of 300 cases. And you can see similar results for sensitivity and the ROC, indicating that biparametric MRI without contrast medium is a valid alternative, but only for expert readers. So one way of getting around this is to do real-time monitoring to decide on the need for contrast medium. But a lot of us are unable to monitor the scans as they are being undertaken. Finally, one could use a biomarker such as PSA density when deciding on the need for biopsy after a biparametric MRI scan, because we expect the proportion of PIRADS3 to increase. So here, for example, is data from the BIDOC study where people with negative MRIs, equivocal MRIs, and positive MRIs underwent different PSA thresholds for biopsy. So you can see, for example, if you had a negative MRI, a PSA threshold of 0.2 was chosen. If you had an equivocal MRI, a PSA threshold of 0.15 and above was chosen, and everybody with a PIRADS 4 or 5 case underwent a biopsy. Now, if you did that, these are the results you would obtain in 1,000 patients. So, for example, if you only biopsied patients who were 3, 4, and 5, you would avoid 300, 30% of biopsies. However, if you adopted the strategy, which is what I've just said, a negative MRI with a PIRADS with a PSA threshold of 0.2, an equivocal MRI with a threshold of 0.15, you can see more biopsies are avoided and there are fewer insignificant cancers that are diagnosed. However, the ability to detect clinically significant disease that's in the population is not impaired. So here are my conclusions. There are positive benefits of using contrast medium when trying to diagnose prostate cancer using MRI. It can help overcome DWI technical failures. It can help us explain the cause of a raised PSA, both benign as well as malignant. Undoubtedly, it highlights look-at-me lesions. It also helps to diagnose non-malignant causes of a raised PSA, such as prostatitis, atrophy, or PIN. It can help risk stratify PIRADS3 lesions in the peripheral zone, which is why it's incorporated into the PIRADS system, and it improves the confidence regarding the nature of the detected lesions. My view is that currently the use of contrast medium enhancement helps to ensure the delivery of the MRI pathway for men with suspected prostate cancer. I hope these arguments have been forceful and convincing. Leave me a message if you disagree. and I know many do disagree. Thank you very much. Bye bye.